Hello, everyone. Thank you very much for joining us for today's webinar. I am very happy to be here with Professor Ricardo Budde from Erasmus Medical Center to discuss real-world results, cardiovascular care with the world's first photon-counting CT. Dr. Budde, hello, welcome.
Thank you, Matt. I'm very excited to be here as well to talk about this exciting technology and really looking forward to this webinar.
Really appreciate your time, and thank you everyone for joining, and let's get started. So when you think about CT in general, not just cardiac CT, but CT in general, why do we do CT? We do CT because of the detailed anatomical structure that we can get. We can get high resolution detail of coronary arteries, of valve leaflets, of plaque, but that comes at a cost of radiation dose. So it's always a balance between what do we want to see and what are we willing to expose our patient. If you have the right scanner with the right type of acquisition speed, say a dual source CT, you can stop motion. And that's obviously critically important in cardiovascular CT. The heart is the fastest moving organ in the body. And so in order to appropriately characterize the heart, first we must stop it. So speed is critically important. If you are looking into the industry, say for the last 10 to 15 years, the idea that has been throughout is trying to go beyond just structural image, looking at composition and function. And we do that with what has been called dual energy or multi-energy imaging, spectral information. The challenge to this point is that there has been no scanner on the market that could do high resolution at low dose, scan extremely fast, as well as getting spectral information all at the same time. That's the promise of photon counting CT. That's what we are excited to talk about today, and that's what we have been able to deliver with the world's first photon counting CT. What does it do? It provides better contrast-rich images, especially in the presence of things like iodine and calcium. We have much smaller detector pixels. That enables higher spatial resolution, but doing it at the same radiation dose that we are used to. We get spectral information in every scan because we measure the energy of every single incident X-ray on the detector, giving us the ability to understand composition and function. And because we have that energy information, we can readily differentiate between what is a real signal and noise. So with that, we can completely eliminate electronic noise from that mechanism. Therefore, we can reduce dose and improve image quality. All of this, we call at Siemens quantum technology, or in the more commonplace, photon counting. So what is a conventional detector? What do you have today if you don't have a NAEOTOM Alpha? You have a scintillator-based system. It's a ceramic material, this gray material here. When it is impacted by an X-ray photon, a light impulse is created. That light impulse is proportional to the X-ray energy, so a small amount of light for low energy, large amount of light for high energy. We measure that energy at the bottom or at the side with a photodiode, and we control where the light goes by putting walls between detectors, septa as they're called. This controls the light so that we can have appropriate spatial resolution. If you want higher spatial resolution, you build a detector with more and more walls. The downside is that every time an X-ray hits a wall, it doesn't create light. And so you get less and less efficient with a scintillator-based design. The other downside is that measuring light is actually slow. In a normal CT scan, you get about 1,000 projections in one rotation and about 30,000 X-rays in each projection. The time that it takes to measure the light means that we average all of those together. So some are low energy, some are high energy. We just get a mean energy. All of that spectral information is gone, and so we've had to develop dedicated solutions such as dual source, dual energy, in order to capture spectral information. So we lose information because of this two-step process where X-rays are first converted into light and then measured and converted into an electrical current. With a photon counting detector or a semiconductor material, that's different. No longer a ceramic scintillator, it is a crystal semiconductor. The easiest things to see right away is those walls between elements are gone. We no longer need to control light because there is no more light. This is now a direct conversion from an X-ray impact to an electrical current. The other thing that you'll easily notice is that the detector elements are smaller. Siemens has been leading the industry with the somatome force for a number of years. The NAEOTOM Alpha and the detector design we have here has 9 times the number of detector elements than even the somatome force. And you see that because of how much smaller we are, enabling us to get much higher spatial resolution. So no more walls, smaller detector elements really allow us to push the boundaries of what we can get. Obviously, we get much higher spatial resolution by default in standard acquisition modes, but we can go to ultra high spatial resolution without the need of extra comb filters that waste half of the radiation dose. So we can do high resolution imaging and ultra high resolution without any dose penalties. I mentioned the ability to measure real signal versus noise. That gives us that ability to completely eliminate all of this electronic noise and only focus on the true signal, giving us better image quality, giving us more stable, reproducible Hounsfield units, and getting rid of artifacts that we typically associate with the merging of electronic noise, which always happens on a conventional energy integrating detector. One threshold eliminated the noise, but this system allows us to apply up to 4 energy thresholds, allowing us to do multi-energy imaging. Today, that means the types of dual energy acquisitions that we would have thought of before, but also opening the door in the future for things like multiple contrast agents as those get cleared by the FDA for further use. So really a wide open door of possibilities with the spectral information always available on the detector. And because we measure each X-ray individually, we treat them the same. A scintillator can't do that because it's based on the amount of light. And so a low energy X-ray really is not treated the same way as a high energy because there's so much more light. That's what you see here in this diagonal curve. With photon counting, we treat them the same. That's why it's straight across. That gives us better contrast. That's why de novo, we will have better iodine contrast, better calcium contrast in the image without doing anything else. And so really this offers a tremendous amount of value to you in terms of image quality. So quantum technology, photon counting, but we've built it into the world's highest end cardiac system, dual source CT, same speed and power that you would associate with the somatome force, 66 millisecond temporal resolution, 74 centimeter per second volumetric, single heartbeat coverage, the ability to do any patient, any heart rate, anytime, the most complicated structural heart patients to complicated, very heavily calcified TAVR and coronary patients. We will use this technology to unveil impressive new details, high resolution at low dose, but ultra high resolution even at standard dose, really allowing us to push the boundaries in cardiac imaging of what we could do. The force, as I've said, is really the benchmark in the industry today in terms of image quality, but we can do even better than that with the NAEOTOM Alpha. If you zoom in and compare these calcified coronaries, you can see the better detail on the NAEOTOM Alpha, even compared to the somatome force at a standard resolution mode. Stents have always been a challenge, not because it's metal artifact, but because we don't have the spatial resolution to accurately depict inside. And so you get these dark rings because of a lack of spatial resolution. Well, with photon counting, more detector elements, higher spatial resolution, we can accurately depict inside the stent lumen so that we can evaluate for things like restenosis without sending someone to the cath lab. Here you can see another example. Again, every image is spectral multi-energy. You can see this same image, 50 keV, 65, 75, 90. As we change that energy level, you can see the importance of iodine changing, but you can also then see the patency through this stent as I spin that CPR around. We have now the ability to really dive deep with high resolution, looking at plaque, looking at calcium, and trying to eliminate the effects of blooming. And as you can see, the difference between a 0.6 and a 0.2 millimeter slice here is quite remarkable in what you would see. The detail that you can get from this could change your clinical decision-making pathway, or it could give you more information about plaque. In a paper recently published by the group from Zurich, compared the image quality that you would see with standard resolution and high resolution, and look at the difference in the ability to visualize coronary plaque and coronary calcification. We can also use spectral information in new ways, because now we have full spectral information at full temporal resolution and full volumetric speed. That means we can use it on the heart and on the coronary arteries, and we can use it, as you see here, to eliminate calcium but maintain iodine. We get better image quality and, as I said, better overall image contrast in the image. You can see another example of that pure lumen technology where we maintain the iodine but remove the calcium. You can see this heavy calcium blooming effect that we see in the image, and then with it removed. What is the accurate lumen? What vessel or stent would fit through here? It's challenging to measure. We learn, we decide based on experience where to decide where the vessel really is. This gives you a clearer picture to make a more confident measurement and diagnosis. We can use that better contrast information to our advantage, maybe to reduce injected contrast material. One of our collaboration partners recently did a study where their IRB limited them to 200 milliliters of contrast, which worked out well because their clinical protocol in this lower extremity runoff was 145 mLs of contrast. They got a nice scan, visualized all the way down to the end of the leg. But when we took them to the photon-counting CT, we only had 55 mLs left. But because of the better contrast, the ability to use lower monoenergetic imaging, I would argue this image could be perceived as better image quality, and it had about 1/3 the contrast dose. Everything else was the same: slice thickness, radiation dose. We just have better image contrast with the photon-counting detector. We can provide meaningful answers without compromises. No longer is it speed or spectral, high resolution or low dose. We can do all of these things together, even spectral imaging at full volumetric acquisition speed. We can use that in the heart for a variety of things. We already talked about the pure lumen, the ability to remove calcium from the vessels, but what about expanding further? We are working with our partners on this application currently, still in the developmental stage, but a number of people today use MR for measuring extracellular volume fraction. It's a very long process, requires a long MR sequence and a long amount of time in the magnet. With this technology, our collaborators have already demonstrated that you can do a single scan at 6.5 minutes, contrast and post-contrast. We can remove the contrast, show the contrast, combine them together to calculate extracellular volume fraction maps. Really changing our ability to look at scar imaging, doing it very simply in CT without having to wait the approximately 1 hour that you would do it in an MR. So really the technology is redefining what we think about with CT, unveiling impressive new details, unlocking new patient groups such as those with a very high calcium burden, providing meaningful answers. Every scan is spectral. Every scan can be high speed and higher resolution, and really doing it with the consistency and quality that we get without variations, because every scan is spectral and monoenergetic. So really the technology is pushing the boundaries, and I'm excited for you to see some additional clinical examples from one of our users who's been pushing the boundaries already for about a year. Professor Budde, again, thank you very much for joining us today. Really excited to see your cases and what you are ready to share with us. So thank you. The floor is yours.
Thank you, Matt. And as I said in the beginning, I'm excited to be here. Thanks again for inviting me. It's always a pleasure to talk about technology, which you are really excited about. And we are fortunate that we have a photon counting scanner in our center available. So I'm from the Erasmus Medical Center in Rotterdam, the Netherlands, which is the biggest or one of the biggest academic hospitals in the Netherlands. And we have an extensive cardiovascular imaging program. Also on the clinical side, we treat everything from regular coronary artery disease up till patients after heart transplantation. So a very diverse population, also including a lot of aortic pathology. These are my disclosures. So why would we even need photon counting CT with high resolution and ultra high resolution scanning? Well, of course, we know that, especially for coronary CTA, it is excellent in ruling out coronary artery disease. But we also know that with conventional scanners, there's still room for improvement, especially in the field of reducing calcium blooming artifacts. We want to improve in-stent imaging of coronary stents. We also want to visualize smaller arteries. We want to do more detailed plaque imaging, allowing also for more detailed quantitative plaque assessment. And not so much in coronary imaging, but in cardiac imaging in general, we want to do more detailed imaging of prosthetic heart valves and endografts. And of course, we want to reduce metal artifacts if we have implants in a patient. And if we can do that, that will improve the diagnostic accuracy of CT, making more patients eligible for coronary CTA, and will probably lead to improved vessel segmentation. And we want to do all of that, but we definitely want to maintain the temporal resolution, because that, of course, is key in cardiac imaging, and that is what dual source imaging provides. And we want to keep that advantage, and the photon counting scanner has it because it's a dual source system. So at the moment, we have two types of acquisition modes that we can use. We can use the default mode, which we call the high resolution mode, where we have a collimation of 144 slices of 0.4 millimeter thickness. And of course, since it's a dual source system and a dual detector system, it's 2 times 144 times 0.4 millimeters. We can choose from a range of KVs, and we can do prospective as well as retrospective and high pitch scanning. We can also choose to do ultra high resolution imaging, where we have a slice thickness of 0.2 millimeters, and we can use 120 slices. So the coverage is slightly less, but we get a factor 2 improvement in slice thickness. We can use that with 120 kVp, again using prospective and retrospective gating. And importantly, for both acquisition modes, the rotation time is 0.25 seconds. So a very fast rotation time, further aided by the fact that it's a dual source system. So essentially essential in keeping the temporal resolution as high as it is. Then there's also the possibility to use iterative metal artifact reduction to significantly reduce artifacts induced by metal. And the spectral capabilities are always present when using the default high resolution mode. As of yet, not yet in the ultra high resolution mode, but I'm hopeful that it will come in the future as well. So as Matt already explained, with spectral imaging, what you can do a multitude of reconstructions when doing a single acquisition. You can do monoenergetic images at different KEVs, and that might help to reduce the amount of contrast material that you have to inject into the patient, because you can go down to lower KAVs, reconstruct those images from your initial acquisition, and going at lower KAV will mean that you increase the attenuation of iodine without increasing the iodine dose. So you can make the contrast much denser, and of course that might reduce your iodine, the amount of iodine that you want to administer to the patient. We can also do virtual non-contrast and pure calcium reconstructions, where we actually remove the iodine from the images, from the CTA images, using spectral decomposition. So that allows you to look at the calcifications in more detail if you have a CTA. Then we can also look at the iodine distribution, as can see in the blue square over here, and we can do also a different visualization where we provide an iodine color overlay map showing us the contrast amount and distribution throughout the anatomy, and that might be useful especially in perfusion imaging. We received our photon-counting CT about a year and a half ago on March the 17th, 2021, and we were able to scan our first patient already 2 weeks after the installation on the 1st of April in 2021. And we are now using it in our daily clinical routine, where we, like I said in the beginning, have a very busy cardiovascular imaging practice, and we do cardiovascular imaging on the photon-counting CT on a daily basis. And one of the things that immediately struck us when we started to use the scanner is the level of detail we get already with the default 0.4 acquisition mode. Some example images here, you already see the sharpness of the images, the level of detail that you can see of the coronary arteries and also of coronary plaques, especially also in combined plaques where you have both calcified and non-calcified components. So that immediately became apparent that we have a reduction in the amount of noise, and we get sharper images at higher resolution. And we need to take advantage of that, and that is, I think, an important thing to remember when you start using this system. We first started off by using the kernels as we would use them on the force. So typically for a coronary CTA, we would use a BV40 kernel, as you can see here on the an image on the top here. But we see that we can go up to much sharper kernels on a routine basis. So BV48 kernel from the same scan, reconstructed so with BV40 and BV48, notice that the level of detail and the sharpness, especially of the edges of the calcification with BV48, is much higher. The plaque is sharper, and although you get, of course, a bit of increase in noise, it is not as much as you would get with an energy integrating detector. So you can go to sharper kernels on a routine basis when scanning with the photon-counting scanner. And that allows you to see much more detail. For instance, in this patient, there is an obtuse marginal branch. It's a relatively short, small vessel, as you can see here. But notice when we make a reconstruction perpendicular to the vessel axis, notice the amount of detail that we can see from this plaque. It's not only non-calcified, there's a small calcification over here, and I think this is truly amazing that you can see this level of detail in these small vessels using this technology. Of course, stent imaging is a challenge. It has already been alluded to in the talk by Matt. And that is where photon counting is helpful as well. This was a 61-year-old patient who received a stent in the LAD for a non-ST elevation myocardial infarction some time ago. And we performed the CT for follow-up of stent patency using the default acquisition of 0.4 millimeters. Because if we use 0.4, we get a larger Z-axis coverage. We use prospective EKG triggered acquisition, so we can image the entire heart here and even a bit more cranial and caudal in only three rotations for this scan. Notice that the stent lumen can be adequately assessed. We can nicely see that this stent is fully patent. There's no stenosis, there's no thrombus formation, there's no intimal hyperplasia in the stent. And interestingly, the patient has a large plaque in the LAD, which was probably the cause for his non-ST elevation myocardial infarction. And the plaque has been pressed into the wall of the LAD by the stent. And you can very nicely appreciate the relationship between the stent and this plaque. And as you can see here, the stent is fully expanded. There's no impression from the plaque onto the stent causing stenosis whatsoever. So fully patent stent, which can be adequately assessed by using photon-counting CT. What I like about the photon-counting scanner is also the fact that we can do high-pitch acquisitions, which is something we routinely use in patients that are being scanned prior to pulmonary vein ablation to determine the anatomy of the pulmonary veins. And we do that with a flash acquisition. And this protocol is not specifically tailored for coronary assessment because usually these patients have higher and irregular heart rates because they have atrial fibrillation, and we're not primarily interested in the coronary arteries in these patients. But this is an example of one of these scans. So the heart rate was relatively low in this patient and relatively regular for an atrial fibrillation patient. But notice that we could also very well assess the coronary arteries from this high pitch acquisition as well. Also notice that the calcifications, for instance here proximally in the LAD, there's almost no blooming artifact. It's really sharply demarcated, and it allows you to assess the lumen of the coronary arteries in great detail. And this was done at a radiation dose, which is, I think, very low. The DLP for this acquisition was 62.5. So depending on the conversion factor that you use, that will result in a radiation dose of just over or just under a millisievert, which I think is pretty impressive for this level of detail we can get. We also do a lot of imaging in patients after heart transplantation, and these patients usually are on medication which has a side effect that they increase in size, so they become bigger, they gain weight. It's not something they can help. It's due to the medication, so that provides a challenge. The other thing is that after a heart transplantation, usually the heart rates are relatively high. So that's a challenge for imaging these patients, but we do it on a routine basis. And this is an example of a patient with a BMI of 33, which is quite high, especially for European standards. And this patient was scanned both on the photon-counting CT and on the somaton force 2 years earlier. On the left-hand side, you see the EKG trace of the acquisition on the photon-counting scanner. We did this in 5 steps because this was an ultra high resolution acquisition. And if we compare that to the acquisition on the force 2 years ago, there were fewer stacks, but also notice that the heart rate is similar. At the force scan it was around 80, well, it's similar to what we see now. And also the total radiation dose, the DLP, is similar for both scans. Then when we compare the images, we immediately see that we have a similar attenuation of the contrast material in the aorta. It's around 590 versus 579 on the force scanner using the same slice thickness and reconstruction kernel. But notice that the standard deviation of this measurement is less than half on the alpha. So a substantial increase in the or decrease in the noise level using an acquisition on the photon-counting scanner compared to the force 2 years ago. And when we compare the image quality on the force with 0.6 PV49, of course it's diagnostic, it's nice image quality, we can assess the coronary arteries. But when we compare it to the NAEOTOM Alpha, reconstructing at 0.6 BV48, so using the same slice thickness, we already see that the boundaries of the vessel are sharper, there's less noise in there. And then when we step up to the 0.2 reconstruction, we can see that the images get even sharper, and we can really assess the lumen of the coronary artery in much more detail. Of course, there are no calcifications, almost no plaque in this coronary artery, but it shows the amount of detail you can get. This is an example from another patient, also a transplant patient, which was scanned 2 years ago on the force and now on the alpha. There's a small calcification here in one of the coronary arteries, and notice the improvement in the accessibility of the vessel lumen. Here you can see it also on the older scan and here in the perpendicular views. Notice that with the photon-counting CT, the delineation of the calcification is much sharper, and it's much easier to assess the remaining lumen of this coronary artery. Another example, a very complicated patient after a heart and lung transplantation. So, of course, not a patient you would see every day. That was referred to us for coronary assessment. We used a prospective EKG triggered acquisition mode. This is the EKG trace. Again, high heart rate, around 85 beats per minute. So definitely a patient where you need a high temporal resolution to scan these patients adequately. We did the acquisition at 0.2 millimeter slice thickness, but we first reconstructed the images at 0.6 using a BV40 filter. Well, I think this is already very nice image quality, especially when you look at the proximal LAD, for instance. Notice the calcifications here, they're already relatively sharp. Also here in the RCA as well as in the circumflex. But when we then reconstruct the images and really pushing the system to its boundaries with doing an 0.2 BV72 reconstruction, here we can really see the improvement and look at the sharpness of these calcifications that are here in the coronary arteries. It's almost like it's being drawn with a very sharp pencil, and you can see that it's not only calcification, but there's also an amount of non-calcified plaque. And I think this level of detail is, well, it's fantastic and amazing that we can see that in these patients using this very thin slices and sharp reconstruction kernels. It's not only the coronary arteries you can see in much more detail, also other structures. For instance, here on the left-hand side, we see the mitral valve. We can even see the chordae tendineae in this patient. But also the tricuspid valve here on the right side of the heart, of course, seeing the leaflets, which is something you normally don't see on a CT scan, and especially not in this level of detail. Again, showing that you also with the 0.2 acquisition, you can go up to much higher and sharper kernels, and the effect it has on the appearance of the images. Even when you compare it to 0.6 with a BV48, it's already quite a sharp kernel. With 0.2, you can often step it up even more to BV56, and that will further decrease the blooming artifact we see around calcifications, allowing us to better assess the lumen of the coronary arteries. What we regularly do now is that we reconstruct several kernels in the scans. And like I said in the beginning, when you start using the system, you need to get acquainted with it. You need to get a feel for the images, and you need to be aware that often you can go up to very sharp kernels and really push the system as far as you can go. And notice the differences you can see. So these are all in the top row, all images reconstructed at 0.6 millimeters. Then we have a row of 0.4 and then a row of 0.2 thickness with BV40 BV48 and BV56 kernels. And you can see the difference, and you can also see that with 0.2 you can often go up to high kernels and really get this sharp image quality. Using different kernels is reducing the calcium blooming artifact. That has also been quantified in this very nice study from the group from Zurich, where they scanned patients with 0.2 millimeter and they reconstructed these images with a range of kernels and then determined the amount of blooming artifact. And what they found is, for instance, if you compare a BV40 reconstruction, BV40 kernel at 0.6 slice thickness reconstruction with a 0.2 at BV56, you get an almost 16% reduction in the amount of blooming artifact. So that really helps you to further or be better able to assess the lumen of the coronary arteries. Using these thin slices and the improved spatial resolution is also going to result in differences when you quantify the plaques. And I think this is a very interesting area. Of course, as everybody knows, there's a huge amount of interest in plaque quantification. It has always been a bit difficult with thicker slices, but now with the very thin slices, the edges become much sharper, so we can really discriminate different parts in the plaque from each other. So we can discriminate calcified plaques from non-calcified plaques and the lumen and the vessel boundary. And again, very nice work from the group from Zurich, where they quantified a number of plaques in patients and compared different slice thicknesses and reconstruction kernels. And what you can see here in this upper graph is that when you look at the total plaque volume of a plaque, when you segment it using thinner slices and higher or sharper kernels, you see that the amount of plaque actually which you measure is reduced. And it's interesting to see when you split it out into the different components, you see that actually the amount of calcified plaque is reduced when using thinner slices and sharper kernels. And that's, I think, not surprisingly, of course, because you get rid of the blooming artifact. So actually the calcium will be smaller, and we see a very slight increase in the amount of fibrotic and lipid-rich plaque. So very exciting field, I think, that is going to provide us with a lot of information in the coming years on plaque quantification and improving that part of cardiovascular imaging. And using this ultra-high resolution imaging is also going to reveal new pathology. This is a patient we scanned recently, again undergoing CTA for pulmonary vein ablation planning. We did this at 0.2 slice thickness. Again, great image quality of the coronary arteries, but also in this patient I found that the left coronary cusp of the aortic valve actually appears to be thickened when you compare it to the other valve leaflets. And due to the level of detail we have, we're going to see new things like this, and I think there will be a number of things that will be exposed by using this high level of spatial resolution, and it's going to show us new things about anatomy and about the heart that we didn't even that we couldn't see before. So a very exciting field, I think. I already showed an example of a stent with 0.4 imaging where we can further improve it using 0.2 slice thickness. This is a patient that has a stent in the LAD, heart rate of 69, scanned using prospective EKG triggering. We can really nicely see the stent in the LAD here, which is fully patent, confirmed by the invasive angio, which was also performed in this patient for other reasons. Also, the circumflex and the RCA have a good image quality and can be very well assessed. What I particularly like in this case is that we can also see that the impact of calcifications next to the stent, so in the coronary artery itself, because yes, the stent is patent, but we do see, and we can also see it here on the cross-sectional images exactly at this level, that there is this slight indentation here of the stent due to this calcification next to the stent, and we can also kind of see it here on the invasive angio as well. So again, going a step further in spatial resolution, showing us more detail than we would have with regular CT scanners. Of course, pre-TAVI planning is also a field where we do a lot of CT imaging. An example here of an 80-year-old female, BMI of 30, which was referred for a scan for TAVI planning to us. Well, we always do a 3-step scan protocol. We first do a non-calcified or non-contrast enhanced scan to determine the calcifications on the aortic valve. Then we do a prospectively triggered acquisition of the aortic root and the heart to determine the size of the annulus, and then we do a flash scan from the base of the skull to the femoral arteries to assess the access route. And this was a difficult patient because the calcium score was sky high. It's almost 1300. And the heart rate was all over the place, very irregular, high heart rates of 133, and then dropping to 62. As you can see, it's all over the place. But still, we were able to get a very good image quality, especially, for instance, when you look at the aortic valve leaflets. I mean, there's a small calcification here in the leaflet, and when we zoom in on that, I think it's amazing that we can really see this. You can even see that it's still covered by part of the valve leaflet tissue here. Also, the coronary arteries. If we would reconstruct the images with 0.6 BV40, we get relatively nice image quality, but still it would be difficult to assess whether this is a significant stenosis or not. But when we reconstructed 0.2 BV56, it becomes much clearer, because now we can get rid of most of the blooming artifact and assess the level of stenosis we have in the coronary arteries. And this is an exciting field as well, I think, where in the future we're going to see that we're going to do less invasive coronary artery angiograms in patients prior to TAVI, where this, at least in my hospital, it's still the case to do this on a routine basis. But I think in a number of patients we can replace that with CT and with photon-counting CT especially. Then doing the flash scan for the access route. This patient had 2 hip prostheses with a lot of metal artifact, but then using the metal artifact reduction technology allows us to get rid of those, and here we can nicely appreciate the femoral arteries in the groin region and determine the diameter, and to see if the access route is suitable for a transfemoral approach. So another valuable addition to the possibilities the scanner offers. Then after valve implantation, of course, with transcatheter heart valves, hypoattenuated leaflet thickening is a big problem. We've done a number of scans in these patients using the 0.4 acquisition with spectral capabilities, where we can look at the leaflet thickening, determine if there's any iodine uptake. We can do monoenergetic reconstructions using either a lower or a higher KAV to assess the stent frame, look at calcifications. Interesting information we're going to obtain by that, and I think in the future, especially the iodine distribution in these thickening is going to be interesting to see if that is going to be something that's going to be helpful, for instance, in determining response to treatment. Of course, there are also patients that get a percutaneous valve in the pulmonary position, and we have a number of those cases as well. This is always difficult, and the reason is that they perform pre-stenting before they insert the valve. So first a stent is placed in the pulmonary artery, and then the stented valve is implanted in that, because they want to have a better landing zone. What you end up with is just basically a lot of metal in the pulmonary trunk, and we scanned this patient using the spectral, 0.4 with spectral, and when we reconstruct at monoenergetic 70 keV images, you see that there's a lot of artifact and it's difficult to assess the valve lumen. Of course, we can change our window and center level settings that gets rid of part of the artifacts, but then we also, of course, end up with that the attenuation of the iodine is reduced in the image, so then it's still difficult to see. Well, one trick we can use is that we can reconstruct the images at a very low keV setting, so at 40 keV, so we increase the attenuation of the contrast material. And then when we do a similar window center setting, we get rid of a lot of the artifacts from the valve and the stent, and now we are able to assess the lumen. So I think using these kinds of tricks and possibilities allows to use this technology in the most optimal way. Transcatheter heart valves, we scanned a number of those valves ex vivo. It still amazes me how well we can see these stent frames and the details we can see. For instance, here, this is a valve that has a small marker with a C in there. I mean, you can see it on the CT, on the volume rendered images. I think it's amazing to see. Also, in this valve type, for instance, these little metal details here are very nicely depicted on CT. Another valve that has a lot of metal. Notice how you can really nicely see the struts in this type of valve, and also in this one, which is commonly implanted, of course. Notice how we can very nicely assess the stent frame. Very high level of detail that we can see. Those were, of course, ex vivo valves, but we can do it also in patients. An example of a patient after a valve-in-valve TAVI. That we scanned using retrospective EKG gating. We can nicely see that the base of this valve leaflet is thickened, and the tip here is still normal. Also notice the aortic wall. See how well we can see that. We often, of course, don't on CT, but here you can actually see the wall itself. Amazing to see. As I said, retrospective gating, so we could also do reconstructions at different points in the RR interval. Looping these allows us to assess the leaflet mobility. Again, showing that this leaflet, although it's thickened at the base, it still opens well. Again, available in high detail. And then, of course, the coronary arteries, which we get for free in this patient and could also be nicely assessed. Combining that, a patient after TAVR and stent placement in the left main, notice how well we can see the stent, and again there's a large calcification here next to the stent, causing actual compression of the stent at this area and stenosis, which is even better seen when we do a cross-sectional reconstruction at this specific point in the coronary artery. So when to use which protocol? Well, I think we are still learning, but when we compare it, I mean, the high resolution default protocol has the advantage of having a larger Z-axis coverage, which of course will result in shorter scan times because you need to have less stacks, and still the spatial resolution is very good and the temporal resolution is excellent. You have the ability to do spectral recons, which of course might help to reduce contrast dose and the iodine content of contrast material if you use a different concentration. Ultra high resolution imaging, smaller Z-axis coverage, which of course will increase your scan time and you will have more stacks. But the spatial resolution is of course better than with 0.4, and you've seen the examples in the presentation, especially a further reduction in blooming artifacts, and still having the excellent temporal resolution. No spectral information for the moment, but I'm hopeful that will change in the future. So how do we do it in our hospital? How we decide on what to use? If you look at TAVI planning scans for annular dimensions and coronary assessment, we tend to go for the ultra high resolution imaging because we want to see if we can reduce the number of invasive angios, and these patients often have, of course, a lot of calcification in the coronary, so we take advantage of the ultra high resolution imaging. For planning of the access route, we use the default protocol with a high pitch acquisition, allowing for a fast scan speed, and also because we plan this scan immediately after the scan for the annular sizing. If the contrast, if we are a bit late with the scan, we can use the lower mono E reconstructions to increase the attenuation and still get a very good opacification of the iodine in the aorta and the femoral and iliac arteries. Doing follow-up after TAVI for valve functioning, ultra high resolution will provide the best spatial resolution to look at valve leaflets, of course, looking at Fuld. On the other hand, if you would do it at 0.4 spectral, you would be able to still get a very good spatial resolution and then quantify, for instance, iodine uptake in the valve leaflets. Looking at pulmonary vein isolation planning, we typically go for the 0.4 using a high pitch acquisition. Also, because if there are doubts about the amount of contrast material in the left atrial appendage, we can quantify that, and that helps us to discriminate a true filling defect due to a thrombus in the left atrial appendage from just a mixing artifact or slow flow. For coronary imaging, what we first do is we assess whether there's a need to reduce the contrast dose or to keep the scanning as short as possible. So if we have a patient with a poor kidney function, if we have somebody that has dyspnea that cannot hold their breath very long, we go for the default acquisition because that's a faster scan with less stacks. If that is not the case, and if there's a stent present, we go for the ultra high resolution mode because we want to get the best spatial resolution for in-stent accessibility. If there's no stent present, but we want to do a very detailed plaque assessment, again, we go for the ultra high resolution mode. If that is not the case, and in most patients, of course, with stable chest pain, they come in through the outpatient clinic or referred for coronary imaging, and we often don't know that much about them. What we always do is that we first do a coronary calcium scan. If the calcium score is 0 or low, I think it would be good to do a spectral high resolution scan. So the default scan protocol, you end up with probably enough information, having a faster scan and good image quality. If the calcium score is moderate or high, I think doing ultra high resolution is beneficial because in that way we will have the best ability to assess the lumen with the least amount of blooming artifact from the calcifications. When we combine it all, I think there's a lot of interest in a lot of new technologies to look at coronary arteries, plaque characterization, FFRCT, all kinds of calculations. I think those all will benefit from the increased spatial resolution and the spectral capabilities that photon-counting CT is offering. And I think we will see exciting developments in these fields. So in conclusion, dual source ultra high resolution photon counting CT is here today. It has increased spatial resolution, spectral capabilities, while retaining the high temporal resolution. You can use higher or sharper kernels on a routine basis and reduce the calcium blooming artifacts. Different types of acquisition modes are available, and I think it will set the new standards for cardiac imaging and quantification. And with that, I'd like to thank you for your attention.
Professor Budde, thank you very much again. Wonderful lecture. The topic is shows the great capability of photon counting CT for cardiovascular imaging. I just want to remind the audience, if you have any questions, please type them in the chat so that we can address them as they come through. We do have a couple of questions already that I think are worthwhile coming and to address. Professor Budde, John had a question about a comparison of high resolution on this scanner versus what may be commercially available on other scanners, a 0.25 millimeter recon.
Yes, thanks, Matt, and thanks to all the audience for attending this webinar on photon counting CT. I saw the question and also already saw your answer in the chat. I don't have personally, I don't have experience with the other the system of the other vendor, but I think a number of the comments that you make, Matt, regarding this are entirely true. And I think what I really like about the photon counting scanner is the fact that it is a dual source system, and we still have the high temporal resolution, which I think is absolutely key in doing cardiac imaging, because you want to have the highest temporal resolution that you can get, and that's what the system offers. So very happy with that, and I think even that the 0.2 is even smaller than the 0.25 mentioned in the chat from the other vendor. I think what's really exciting is once the full spectral capabilities would become available with 0.2, I think we have to keep in mind that we're still in the very early stages of the system. So I expect there's a lot of new developments on the horizon, and things can only get better regarding that. So.
Yeah, I fully agree with you. And the other thing, again, to consider just for the audience as well, slice thickness is typically how we think about what our resolution may be. I went from a 1 millimeter to a 0.75 to a 0.6 to a 0.2, but it's also in plane resolution. And the photon counting scanner not only is 3 times higher in the through plane in the z-axis, but the in plane detector measurements as well. So it has a dramatic effect. Even if you use a thicker slice, you get benefits of much higher resolution. Another great question, Farhan was asking about contrast agents. Now, just to be clear, I will reiterate it vocally as well. You know, there are country-specific rules and regulations, excuse me, for what agents that you are able to use and for what purpose, so keep those in mind. But I know, Professor Budde, you've had some experience using other agents already. Perhaps you can comment on that.
Yeah, I think, of course, the also with new contrast materials there, I think there will be a lot of developments in the coming years. What we can do at the moment, we can use other agents that are or materials that are available. We have experience in patients that have a severe allergy to iodinated contrast material, going into an anaphylactic shock previously, that had to undergo a CT scan with contrast material where we use gadolinium instead of iodinated contrast material. And what we did is that we used the spectral capabilities to reconstruct the images at a very low kV, so 40 kV, ramping up the attenuation of the gadolinium contrast material. What we do need to keep in mind, though, that you need to increase the gadolinium doses when you compare it to MRI imaging, because of course it's not the gadolinium is not the optimal agent for doing CT, but it's definitely possible. And I think in the patients we've had, it has been a very interesting solution and helpful for us to answer the clinical question. Furthermore, I think development of specific contrast materials in the future, targeting specific parts or in the human body is very interesting, and could even move the field of CT towards like nuclear medicine type of imaging. So but that's for the moment, at least as far as I know, for the future developments. But the gadolinium, at least in the Netherlands, we can do that.
Thank you for that. Another important question from Ken is the process and sort of reconstruction workflow. So you know, from the Siemens perspective, we recognize that you could want to do 0.2 millimeter, 1 millimeter increment overlapping 1024 matrix slides on every patient, because it just sounds like it would be valuable. But in reality, from a physics perspective, it's not. And so we've actually built intelligence into the system that evaluates the field of view that you're looking at, the reconstruction kernels, and the task at hand to make a suggestion automatically for a matrix size, what we call auto mode. And so that will look at the task at hand and say, does a 512 matrix make sense? Does a 768, 1024, et cetera? And so we try already to mitigate that problem, make it simple for users. But from an experience perspective, Professor Budde, what have you experienced at Erasmus, and give your experience?
Well, I think we use the automated suggestion by the scanner for the matrix size, which I think is a great help, because data load is something to take into account with this scanner, because of course you have huge capabilities in reconstructing different types of images. So at least having the smallest matrix size, which still allows you for the best resolution, is something which is extremely helpful. I think it's also part of the learning process, looking at different kernels. Which kernels are you going to reconstruct? We started off by doing BV40 kernels, as we did on as we were accustomed to using on the Force, but we are seeing that often we go up to much sharper kernels. So we are now thinking about not reconstructing the BV40 on a routine basis anymore for our coronary scans, for instance. So it's also a process of getting accustomed to the scanner, and maybe deleting some of the reconstructions you have done in the past and going towards reconstructions and kernels that offer you more detail. I also saw that there was a question regarding, or part of the question was regarding the transfer to PACS and single via speed. The reconstruction speeds are not a problem. They are fast. It's not something we encounter problems. It's not different than other systems that we use. So that works well. It's just selecting what you are going to reconstruct. The good thing though is that if you look at the spectral imaging, what you can do is you can send a spectral imaging file to your single VR, for instance, and there you have the capability to later switch between, for instance, a virtual non-contrast reconstruction, or an iodine-only image, or a pure calcium, or a pure lumen. You can do that with the click of a button, which I think is very helpful as well. Also adapting the KV, the mono KV level that you are looking at, and that allows you to send one spectral data set that has all the information to do that. So that's another step that you can take to reduce the data load that you're going to transfer to the PACS system.
Wonderful. Thank you for that. John had another question. John, quantum is what we describe in the process of what's needed for photon counting. Quantum entanglement, no, not necessarily. This is still a CT scanner. Quantum, as in a quanta, we measure every single quanta. But the important thing that we like to remind people when trying to understand this technology, it's not that we just changed the detector. That in and of itself was a massive change, but everything related to the imaging chain had to be redefined and updated for all of these aspects, like the data throughput topic that we were just talking about, and manipulation, how you process the data. And so really it's a redefinition of many of those aspects, and collectively then what we call as quantum technology. I will give one last prompt for any final questions, but again, thank you all for joining us today. It was a pleasure to be here. Professor Budde, thank you again for your time and wonderful lecture. If you have more questions, I will go ahead and stick my email address in the chat, and people can feel free to reach out to me with questions. Both myself and Dr. Budde will be attending RSNA in just a couple of weeks. So feel free to come find us there as well. We will have cases at the Siemens booth. Professor Budde will be giving a lecture on Wednesday on the topic as well. And so if you have questions, we will certainly be available to answer them. With that, I guess I would say thank you everyone for attending, and really appreciate your time. And please reach out if you have any other questions.
Thank you all for attending.